Oncologists work with pathologists very closely in this area. So when a patient is diagnosed with breast cancer, pathologists would always do the estrogen receptor, progesterone receptor, and HER2. Oncologists should guide the decision working with the pathologist as to what tests should be done for the patient next in terms of genome profiling. And not just the medical oncologist, could be a surgical oncologist, could be a medical oncologist. We all want to know what is the risk of recurrence, what is the risk of having a distant metastasis in these patients. And so we need to work very closely with the pathologist to get the right tissue to the right place. Some of these tests are done centrally in a specific company, like the Oncotype test. You have to get the tissue, send it to the company that does this test, and that's the way it is. If you want to do, for example, a Prosigna, then there are different options because these tests can be done in different laboratories. Some of them are large commercial laboratories, and also some institutions are beginning to do that themselves. So there are different options, but it's very important to cooperate with the pathologist, so that the medical oncologist, the surgeon, the pathologist can decide what's the best for their group to do. Next generation sequencing is available. The technology is available in many academic institutions and commercial laboratories. So we can take a tumor and sequence it, and sequence the entire tumor and know what mutations are present in that tumor relatively easily. The cost of sequencing has gone down significantly, and you can now do it in a reasonable with a reasonable time frame and cost, and know everything about that tumor. The question is that information clinically useful or not? And that's, I think, still a little bit early to know how we're going to use this information to treat a specific patient. For example, if we take a biopsy from a patient with metastatic breast cancer and we apply next generation sequencing and find mutations in genes that we didn't know about, how are we going to treat that patient is still unclear. There are some hypotheses, and there is a lot of research going on in this area. For example, the National Cancer Institute is launching a study called the NCI Match, which includes more than 20 arms. Each arm of the study is almost like a phase 2 clinical trial. So what happens is if a patient has metastatic disease of any type, lung cancer, gastric, or any type of cancer, a biopsy would be taken from the metastases. It's sequenced in specific laboratories. And then if they find a specific mutation in that tumor, that patient will be offered a therapy that is targeting that particular mutation. And then we will learn how patients would respond based on that genetic abnormality. So that study and many others ongoing in Europe and elsewhere will help us understand what's the utility of this next generation sequencing in the setting of specific treatments. And that's a very important area of research.